Welcome to Question Healthcare, investigative podcasting in ethics, health policy, and health humanities. I'm your host, Christy Retmeister, and I'm here with our guest, Mark Kashevsky, who is professor and director of the Neiswanger Institute for Bioethics and Healthcare Leadership at the Loyola University Chicago Stritch School of Medicine. Mark has co-authored a case that we will discuss in this episode, and this case was published in the March of 2026 issue of the American Journal of Bioethics. And the article is called "When ICE Brings You the Patient, Hospitals Must Stop Victimizing Forensic Patients." So, as many of you know, the U.S. Department of Homeland Security's Immigration and Customs Enforcement, ICE, has been in several U.S. cities. ICE officers' tactics have been documented, especially those using military armament and excessive force, some resulting directly in the deaths of U.S. citizens, asylees, and anyone they perceive as illegal or as a threat. The case that we'll discuss in today's episode is one in a U.S. emergency department. Mark, thank you for being our guest.
Christy, I am thrilled to be here on the inaugural podcast that you're doing and to have a chance to talk with you again.
So, Mark, can we start with you giving us a summary of the case?
Sure. And this is a composite case that we published in the American Journal of Bioethics, but each element of it has been reported to us as part of a case in which ICE brought people to the hospital. And of course, here in Chicago, a number of months ago, we had Operation Midway Blitz, and that brought a lot of immigration and customs enforcement and border protection agents to our city. And, we were prepared for them from the perspective that, we'd seen increases in immigration enforcement before, and we were thinking a lot about if ICE agents came looking for patients at our hospitals and things like that. We weren't quite prepared for the volume of patients being brought to us by ICE agents. When they apprehend a person, when they during a raid or during any kind of time that they pick up a person, that person may become a patient, because if they are injured, either during the apprehension or if they have a pre-existing condition that is suddenly activated by the stress of being apprehended, they can end up being brought to the emergency room by the agents. And so the composite case that we related is of a young woman. She's in her 20s. She was apprehended at a raid at a local event outdoors at her church, and she is pregnant at the time, and she is under the stress of the situation, says to the officers that she thinks she's going into labor, and so she is brought by the agents into the emergency room, and the emergency room people want to admit her to labor and delivery. And the case really goes through several elements, which is that when she's brought in, the staff want to examine her privately. And of course, this is a young pregnant woman. This is going to be a fairly intimate physical exam as well as history taking. And so it's natural for the physicians to ask the agents to step outside the door and stand outside the door of the room. And the agents say no. The caregivers call security because they believe that security is used to talking to other law enforcement agents and relaying the policy of the institution. And so a security officer comes and does give an information sheet to the ICE agents. And the ICE agents look at the sheet and they hear the briefing from the security officer, and they refuse to leave the exam room because nothing on the policy says that they should. And in fact, the policy more or less counsels them in different language to keep eyes on the patient all the time. The policy very much emphasizes that they are responsible for making sure the patient remains in their custody, that's not the hospital's responsibility. So they should keep an eye on them at all times. The policy says that one arm should be shackled to the bed at all times. And so it goes on like that in fact, the agents are responsible for patient privileges. And so the healthcare providers are very frustrated by this and feel that the patient privacy is violated, they have to examine her with the agents there. And in fact, as things go on, as the patient remains in the hospital, things deteriorate a little bit further with meals being delivered as they are at regular intervals by the hospital to the patient. And the agents start to push the tray out of the way for a couple hours after it's delivered. They don't allow the patient to eat till some arbitrary time, a couple hours afterwards. And presumably, as this was related to us, it was thinking that they wanted the patient to feel a little bit incentivized to say she was okay and to leave the hospital, that they wanted her to be a little less comfortable there than she should be otherwise. And so this opens the whole question for us of that policy that was delivered to the ICE agents, what we call a forensic patient policy.
Thanks, Mark. So I think many of our listeners are going to be unfamiliar with who forensic patients are and what kinds of interactions that so-called forensic patients have with clinicians. And this case draws our attention to some forensic patient policies that do not carefully distinguish between patients who are suspected perpetrators of crimes and patients who are justly or perhaps unjustly in custody of some branch of U.S. law enforcement, or could be local law enforcement. And you and your co-authors seem to be trying to draw some attention to this distinction between just and unjust detention and how carceral detention policies play out, not in carceral spaces, but in healthcare spaces, spaces that are really regarded as the so-called turf of the clinicians, where we're used to really seeing the clinicians as the persons of authority. And that is changed up in this case and really exacerbated by the forensic patient policy that comes to the scene here. So what are a few key points that you'd like our listeners to think about in terms of how carceral policies play out in healthcare spaces?
Sure. And and this is important and a little bit complicated stuff. So we're going to hope your listeners can stay with us here. But, we're right away flipped into some jargon here, right? I started using the word forensic patient policy. And the word forensic probably isn't completely obscure to the listeners from if they listen to watch some TV shows with, investigative police work, CSI kind of shows, right? They hear about forensics, call the forensics team, and that usually refers to the analysis of evidence at a crime scene, or something like that. The analysis of the guilt of a patient, of a person, and things like that. In this case, it's the generic word that is used for patients who are in the custody of law enforcement. We call them forensic patients, and as you say, that can be in a lot of different forms when we say in the custody of law enforcement. And we've long had law enforcement bringing these patients to our hospitals. And as a result, institutions have long had forensic patient policies. I will tell you, and this is very embarrassing, as a bioethicist, I had never read our forensic patient policy and didn't know it existed until Operation Midway Blitz. And, and this is a terrible oversight on my part, but I got to tell you, I think I'm among a few thousand bioethicists on this. I'd had cases before where I was called as an ethics consultant over at hospitals. And the complaint is that a patient is being brought in from a prison where he's been a prisoner for a long time, and he's elderly and infirm, near death, may be intubated, and they say, and the officers shackled his arms to the bed. Why would they do that? And so we go over and we start talking to everybody, and we would eventually, convince everybody involved that there was no threat from this patient because the patient was old and near death, and what we were trying to introduce comfort measures. So we clearly a shackle, a handcuff around your arm is very uncomfortable, and everybody would agree, sedated, we can take that off. And it never occurred to me that perhaps a day or two before, our security had come up there and actually told the law enforcement agents who brought the patient to the hospital that they were supposed to shackle them to the bed. And so these policies have existed in this way that is one size fits all and can be rather draconian in some of these situations. And so I will say, spoiler alert, the upshot of our conversation here in my mind is that we're failing these immigrant patients right now because we have been failing patients coming to us from other carceral settings for decades. And the answer is we have to stop failing all of them. And that's what looking at these forensic patient policies will give us the chance to do. And clearly, I think that at the core of this, and as you indicated in your question, we're talking about different kinds of patients, Christy, is that really what we need is for law enforcement agents and our security to take a quick assessment of the situation and say, what is the risk here from this patient to staff, to the caregivers, to the people around them, right? In the case of that person who's brought from a prison who's dying, the risk to the caregivers is minuscule to non-existent. And this is now being drawn to our attention by this group of patients who are coming to us who are immigrants, because all the data is showing they are not criminals for the most part. That the number of people that are being apprehended who have any kind of criminal record, never mind a criminal record that includes violence, is exceedingly low. And so suddenly we're taking like our pregnant woman in the case and shackling her to the bed and denying her patient rights. And so so what we need is that individualized risk assessment, right? And I don't want to pretend that that there's no risk ever to caregivers, right? Right now, at the time of this recording, Chicago is reeling from an incident at a hospital where a patient shot and killed one law enforcement officer and seriously wounded another, right? That's all too frequent violence against our health caregivers. Nevertheless, we can tell that there are a lot of patients who pose none of those kind of risks to people, and they should be treated a little bit differently. Just much like, we say the minimal amount of restraints should be used necessary to keep a patient well. Same thing with any kind of restraints for the danger or risk posed by a patient, the minimal amount consonant with the risk being posed. And so it may have to be that a lot of times the default is to go to assuming high risk if we don't know, right? A person is picked up by law enforcement and has not yet been adjudicated. They may have been in some kind of altercation. It may not be clear to the law enforcement officers what kind of risk they pose. And the default may have to be, that we assume a high risk. But when we're talking about patients who clearly pose no physical risk because of stature, illness, things like that, and that there's no reason to believe they've committed a crime other than having unauthorized immigration status, there's no reason to presuppose we need that maximum level of restraint on them.
Right. And some of the people being detained don't even have odd immigration status, right? They might be asylees, and it's not illegal to seek asylum.
Correct.
Or they might be citizens.
Yes, right? Good point.
Those are two.
We're getting quite a mix
points
here.
Yeah. So, we can back up too and think about what kind of case this is, because I was impressed by the kind of case this is. Usually in our standard garden variety clinical ethics cases, we have key decision points for the clinicians in the case. Now, of course, this case was written to really evaluate the policy. And some folks argue that policies or good policies are supposed to remove some decision-making authority from clinicians. I think we could argue to what extent that works well in this case. I mean, when you're talking about shackling a person who's neither a threat to themselves or others, we could argue that now we're not talking about a clinical ethics case. We're talking about a human rights case, or interfering with the patient's clinical care, interfering with the patient's consumption of food to which they are entitled as a patient of the institution. These are human rights things. These are not garden variety decision points for clinicians to make. And so I think it's important for us to really recognize that this is a transition in what we see as a legitimate case in bioethics. We normally say, don't focus on bad actors, right? We want to assume that everybody in the case is well-intentioned. So we want to feature that conflict of duties. But we do have bad actors in this case. And the decision points of the individual professional agents is obscured by how that case is written to really evaluate the policy. So I wanted to give you an opportunity to talk about that tension in how you wrote this case, because I know you wanted to feature the human rights things, but also not probably obscure the clinical agency, the professional agency of the clinicians in this case. So take a minute to reflect on that.
Yeah, and that's a very astute question right there, because, it would have been so easy to write this as ICE is the bad actor all the time, 100% unequivocally. And the doctors and and by assumption, the institution they work for are the good guys, right? And we try a little bit different tack on that. We were really saying, we're not saying the ICE agents are the good guys. We're saying they are the uninformed guys. That the institution is failing in their duty to set norms and expectations for them and help them adhere to those, right? Now, they may be good guys, they may be bad guys. I don't know, right? I didn't meet them, right? And there's multiple ICE agents across the cases that went into the composite. But we do know that many of them are fairly new hires. Many of them are not extremely well trained, don't have very extensive training, and may not be very familiar with the inside of a hospital. And so, if we're going to want them to behave according to certain norms, we have to articulate those norms and set those expectations, right? And give them the chance to respond, because they're much more likely to act out, to do things that are outside of what we expect if they feel out of control or they don't know what the norms are. And then people tend to lash out. So the first thing is we need the institution to set those norms. I also think that there's a tension in the way we set this up, which is what I'm seeing around the country, which is, and I hate to have now joined the group of people who are bashing hospital and healthcare system administrators around the country, because, generally speaking, they're trying to do a good job in our nonprofit institutions. But I do think that we do have a suits versus clinicians dynamic going on with these policies, that the bedside caregivers really perceive the need for basic humane treatment of their patients. And that's what we're seeing represented in the case where they want to examine the patient privately. They want patient rights. And administrators are being very reluctant to change these forensic patient policies because they're thinking strictly from a liability perspective, a risk management perspective, and saying, officer just got shot across town at another hospital. It's much better if we just go maximum, restrain them all, no privacy, none of those patient rights. Let's just minimize our liability and be done with it. And so you're seeing a tension between those two groups of people, essentially, in how this is playing out in our institutions.
Healthcare organizations can make policies about any number of things, but all of those policies have to be implemented by individual moral agents. So the clinicians, your chaplains, your clinical ethics consultants, your security personnel, these are the people who have to implement the policies. Part of why you've compositized this case is because you've come across many clinicians who have said, look, I cannot in good conscience do this. But what should happen in cases in which individuals that are called upon to implement these policies say, look, the day you cuffed my patient to a bed is my last day in this institution, or the day that you say that my patient can't eat when they get their food, that's my last day here. So there are clinicians in good conscience, I know many, who would never be able to implement this policy. So what's a clinician in good conscience to do?
Yeah, well, and you're pointing out the classic moral distress situation, right, where the clinician knows the exact right thing to do, that the patient should get their food when it's delivered, and they can't make it happen, right? And so they go home incredibly distressed and live with that. Now, what I've seen done so far is that I really haven't seen conscientious objection invoked and clinicians walk away from the situation for the reason we very seldom see conscientious objection invoked in most morally distressing situations, because the clinician feels like they are abandoning the patient then.
Right.
They want to stay and push for the right thing to be done, and so they go up their chain of command. They talk to their department chairs. They represent to the chief of the medical staff. They push that into the general counsel's and CEO's office, and it takes time. Meanwhile, these cases are playing out, but they're all kind of pushing. They're talking. They're trying to do that. They're at the same time trying to protect people around them, and so developing protocols for what to do if ICE it becomes threatening to those around them. For instance, we've seen situations where officers ask people of color who are on the case, so where are you from? And things like that, as if they're going to apprehend them, and so the clinicians develop scripts with their coworkers to respond to that, but it's slow going and it is dependent on how responsive administration is at certain points, but they try to keep up that pressure because physicians are not completely powerless, especially not in the aggregate. They can push on their health systems.
Yeah, and one of the key questions I think we could ask here is what might a good carceral patient-centered policy look like? And could we use perhaps 2 or 3 upshot points that you might offer healthcare organizations who are looking for advice about how to do this well?
Sure. And the simplest thing is to remember that the other patient policies that an institution has, like the patient privacy policy, confidentiality policy, those actually apply to these patients as well. The medical decision-making policy, the informed consent policy, all those policies that articulate the rights of the patient to make their own healthcare decisions, applied in the forensic patient policies. These patients have the same statutory and ethical rights to make their medical decisions as everybody else. They have the same HIPAA rights as everybody else. And so the first key to making a better, more patient-centered forensic patient policy is to make sure all the rights patients have that are articulated in the other policies are referenced in the forensic patient policy, so that law enforcement is then apprised of the fact the patient has a right to privacy consonant with their risk level. Patient privileges. Now, if you don't say what those are, law enforcement could take a very broad interpretation of that. As you're saying, Christy, being able to eat on a schedule is part of the medical care and a human right. It should be made clear in the policy that when we're talking about patient privileges, we're talking about things like whether the patient can have a TV on in the room, right? Not whether and when they get to eat, whether and when they get to go to the toilet, whether and when they get to sleep. Those things are under the medical care of the team and a human right, and you don't lose those because you're in law enforcement custody.
Right. So this case has really tripped a lot of my radar as a health professions educator, too, because I'm imagining students in the room during these kinds of cases and junior clinicians, trainees. What should health profession students and members of the public know and question about forensic patient policies in the organizations where they're either learning their professions or seeking health services?
One of the first things that people who work in the facilities can do is to look up what is the forensic patient policy, what does it look like, and what's in it. And I've seen some better and some worse. Most aren't very good, but there are some better ones that do articulate things such as patient privacy and some things like the patient retaining the right to make their medical decisions. And so finding out what's in the policy is important. Finding out who owns the policy in the facility. At healthcare facilities, different departments write different policies. And so very often on the top of a policy is which department wrote the policy, who owns it, who's responsible for revising it. Who would you question about the policy? And very often it is your security department or your campus safety, whatever it's called at one's particular facility, often the general counsel's office, or often in tandem between the two. And you could see that if those are the only two perspectives reflected in the policy, that it in fact is going to have a very particular slant. It's going to have a risk-oriented slant, a slant about minimizing liability. And so that can open up a conversation then with those offices about whether you have everything in this you need to handle a situation should you be brought a patient like the one in our article. In a lot of our cities, they're thinking about this like, tornado preparedness. You really could use a good tornado preparedness policy, but you're probably not thinking about it very often. But you want it to be good for when you need it. Community organizations can do this, particularly if you are in a county, say, with a ICE detention facility in it. You might want to start having that conversation with the heads of your institution. Get the conversation going while the stress level's low. It's likely to go better.
So we've considered the intersection of the decision-making authority of law enforcement and its intersections with the scope of the decision-making authority of clinicians in this case. And Mark, one of the other things I'd like you to consider, reflect upon for our listeners are not only those intersections, but how they relate to standards of care and perhaps to the role of conscience. So perhaps there were clinicians in this case who felt like they had to draw upon their conscience to actually perform at standard care levels.
Yeah, and this is a wonderful question, Christy, because I've heard physicians ask me, I've had several ask me, can I be a conscientious objector to discharging the patient? And, one way that I've seen healthcare providers try to provide some equity to this is simply to keep these patients longer in the hospital.
Yeah, so keeping patients longer, if we think of that in ethics term, we might construe that as a conscientious provision of care or a way of guaranteeing longer continuity of care. So there's a key ethics point that has a lot of clinical value and so much value to all the things that you've said here today. Mark, thank you for being our guest.
Thank you for having me, and good luck with your future shows.
And thank you, our listeners, for being part of the Question Healthcare community. To learn more about QOHC or to share a case or question that you might like us to investigate, go to healthpolicyethics.com. Thank you.